Hello there, glad to have you join us on another very interesting edition of Health Matters, reaching you on NTA Channel 12, your dependable station. I am Umar Basidate, and today we'll be having a very interesting conversation with the Chief Medical Director of the University of UUTH Teaching Hospital, talking about Professor Mbasi. Hello, Prof. Welcome to the program.
Thank you, and thank you for having me.
Thank you, sir. And so you know that you don't have to leave. You can't touch that dial, else you miss a whole lot. There are so many questions Prof will be addressing as it concerns the health sector in Akwa Ibom State. So, Prof, first of all, how has the journey been as the Chief Medical Director of UUTH?
Well, I would say it's been interesting. It's also been tough. It's been a journey of discovery. And above all, I'm very happy that it will soon end.
Let's look at the accessibility and affordability in the health sector. What are those concerns? What would be your response to some of those concerns in terms of accessibility and affordability?
Now, for accessibility, we're looking at access to healthcare. I would say that Akwa Ibom State basically is actually blessed, being a state that is quite small, and then it has a very good road network. And in virtually every local government area of the state, we have a secondary health facility. You have many private and primary health facilities in the wards. But how functional are they? That's another question entirely.
That's true.
And then you have the teaching hospital. The major challenge is now access in terms of affordability, because in Nigeria, unfortunately, more than 70% of the patients still have to do what they know as out-of-pocket payments. We do not have this universal coverage. Not everybody is covered. And that's a very major problem here in the University of UUTH Teaching Hospital. It's also sad that as much as 50% of the patients that come here cannot afford, their medical bills. And what am I saying? So even if the best doctor in the world, assuming there's not like the best doctor, right? Mm-hmm. But assuming the best doctor sees that patient, and then that patient still has to do some investigations and cannot afford the investigations. Now, assuming the patient can now manage to do investigations, and then you now write a prescription for the patient, and the patient cannot afford the prescription, then definitely you cannot achieve your desired goal of treating that condition. So it's still a very major challenge, even in the state here. I know that we have a state health insurance, but I think there's still a lot left to be desired in terms of coverage. I'm talking about I'm not talking politics here.
Yeah.
I'm talking about what I see on the ground.
Exactly.
That close to 50%, if not more, of the patients that come to this hospital cannot afford their medical bills. Every single day, I have to waive, bills of people who have in the ward, whose long stay. Because what happens here is that when you come in an emergency, we have to treat you. We cannot, no matter what happens, we cannot watch somebody bleed to death. We have to treat, and then at the end of the day, you cannot afford the bills, you have to waive the bill. I would say that this hospital has never really been known for turning its back totally on a critically ill patient. There may be a limit to what you can do, but the instruction has always been save that life first
of all,
before you think about the bills.
That's how it should be. And having worked with the people of Akwa Ibom State for a very long time, what would you say are the major health challenges here?
I would say the major problem of Akwa Ibom State is inconsistency in health policies. Let's see health primarily as a social service and less of a political experiment.
Of course.
Sorry, I'm using the word experiment. What it means is that now the other thing I would say is that we also need to begin to have a health system approach to health. What do I mean? There should be this seamless coordination between all tiers of health, primary, secondary, and tertiary. We need to stop working in silos. For instance, this is the University of UUTH Teaching Hospital. This is the only publicly accessible tertiary hospital in the state. It's a federal institution.
Yeah.
For many years, absolutely no support from the state government. The number of patients we see here is almost equivalent to almost all the state government hospitals. But yet, no, there was no support. I would thank the present administration, at least we are beginning to see some little support.
Okay, Prof, you know that usually they say prevention is better than cure, and a lot of our people die out of ignorance. So, what is the role of the hospital in trying to ensure that people are well educated in disease prevention, health education? What role do you have to play in this direction?
This is a tertiary hospital. I think that role should be primarily that of the primary health care. You understand? That's where, because what happens is that message has to get out to the communities. Let people know at the community level. There's a limit to what I can do. Basically, first of all, when patients come here, in all our clinics, there's before you see doctors, there's a health education session where the nurses, right, who are trained to do so, would talk to patients and try to tell them. Because rightfully so, most of the health conditions we see are actually preventable. I cannot prevent myself from having hypertension. I can prevent having a stroke from hypertension. So most of these major conditions are preventable. When you have an accident, you don't need to go to a traditional bone setter. I'm not saying they don't do their work, but they believe me, the traditional bone setter, his job is just primary and basic. Yes, if a bone is misaligned, you can pull it and align it, and that is primary healing. But by the time you have multiple fractures, you understand, multiple, or you have an open wound, and you go to traditional, you end up with osteomyelitis and possibly even death. So people need to know that when they have, some of these health conditions, they need to go to hospital. But beyond that, they also need to be educated that some of this, you don't have to wait until you have these health conditions. Yeah. There are certain things you need to do, right, to prevent yourself. I mean, walk into a place once in a while and check your blood pressure. And that would help you know that you are hypertensive. And you watch your diet. Some of these basic things. That's a message. And like I said, it is not that of the hospital alone. It's even that of the media. Yeah. Right? Which I believe that's what we are trying to do in this program. There should be more health programs on all types of media, social media, electronic, and print media. People need to be informed to have a more, be more health conscious.
Okay, yes, Prof, you made mention of people patronizing the traditional birth attendant, and you know that when you interact with some of these women, I've had reasons to interact with them, and you discover that some of the complaint is that you go to the hospital and the treatment meted out to you by the nurses. Some of the nurses are so rude. So, I mean, as an administrator, what do you do to tackle some of these? I'm sure you've had cases, you've had reports.
Yeah, I tell my nurses every day, whenever I have, what I want to say is that in every system there are good people and there are bad people. Unfortunately, the attitudes and behaviors of a few bad people tends to paint the rest of the good people in a bad light. What you're describing probably will be 0.5% of the nurses anywhere, not necessarily. Yeah, did you hear me? 0.5. It means that 99.5 actually know what to do. 0.5 may misbehave. So what I tell my nurses, because what I see, what are the causes of some of these issues, is even the patients themselves. A patient would come and and demand attention, demand this and that. I tell them, and I've said it over and over again, a woman whose child is convulsing is not a normal person.
Sure.
If she shouts at you, please don't shout at her, because if the tables were turned, you would probably do the same.
Or
worse.
Okay, and then that takes us to facilities within the hospital. How adequately equipped is the UUTH? You have enough medical facilities?
You saw me take a very deep breath. Have you heard me? I think UUTH is a tertiary hospital, but I have to say, unfortunately, the resources, for whatever reasons, for many of these facilities, we've done well over the years, because if you ever came to this hospital 10 years ago, it's not the same hospital. Over the last 10 years, in terms of infrastructure, they've been close to about 15 new buildings.
Wow.
Either built up or heavily renovated in this hospital. So it's not, like I said, I came to this hospital in 2004. 4th of January 2004 was when I reported here as a very young consultant. And then most of the hospital was in this building. Right now there are more than 20 buildings. I think we had only about 4 buildings in this compound. I think there were stores, that was the amenity, and the old theater. Was there any other building? That's basically, that's how small, but now the hospital has expanded. So in terms of infrastructure, I think we've done fairly well, even though we could still do a lot more. Over the last 2 years, about 6 new buildings were to commence, but with the challenges of capital releases, the contractors have refused to start. And if you go around, you see about a few of them abandoned because the contractors have not been paid. So in terms of infrastructure, even though we've had a pass mark, I think we could do a lot better. In terms of equipments, I also say that over the last couple of years, we've brought in a lot of equipments. But I'm not very happy. I think the maintenance culture is quite poor. Like I tell my engineers, this hospital has become a graveyard of medical equipments because you are bringing in something in a few months' time. Now, part of the challenge is that the equipments we now have are not the type we used to have. Remember, everything is now made in China. Before they were made in US and all that. But we can no longer afford the US and Europe kind of equipments because of the strength of the naira. So we have to fall back on the cheaper electronic equipment kind of stuff, and then these things do not really last. Part of it is the fault of not maintaining it well, but part of it is the equipment itself. So but then we have a challenge in some of the very major equipments which we need. Our CT scan has been down for a few years now. At the last time, I needed over 100 million to fix it. But in 2024, we had this provision for a radio diagnostic center, which we started. We were supposed to bring in a brand new CT scan, an MRI, fluoroscopy, X-ray, all this high-tech. But unfortunately, that project has not been completed because of incomplete capital. I'm a bit scared when I say these things on air, but it is what it is. Okay. The place is there. We had a new radiology complex. It was supposed to have been furnished state of the art with all these things, but it is not there. But mercifully, again, through partnerships, the Nigerian Sovereign Investment Authority, NSIA, is building an advanced diagnostic center within the hospital. I pray in the next few months that will be fully commissioned. It's actually going to be further down, fantastic place. But I'm a bit worried because that may not be totally openly accessible to people who cannot pay, because it's a public-private, remember, Nigerian Sovereign Investment Authority, MedSev. So it's like something that should recoup its funding. So I'm not sure that these indigent people who cannot have money to pay will have access. So it's still, we're hoping that money will be released.
Okay, we'll take a break now. We'll be right back. Don't go away. Thanks for still being there. So good to know that you are still there. And if you're just joining us, the program remains Health Matters, and we've been having a very, very interesting conversation with the Chief Medical Director of the University of UUTH Teaching Hospital, talking about Professor M. Bassi. And so before we went on the break, we were talking about equipment and all of that.
What I said was one of the major gaps in Akwa Ibom State. Well, I guess the new hospital, international hospital being built by the governor may address that, but until that comes, is that we do not have a cancer center in the state. And what it means is that, and the burden of cancer is huge. If you come to our clinics, our oncology clinics, there's a lot of breast cancers, a lot of prostate cancers, a lot of cervical cancers, ovarian cancers, quite a lot of leukemias and all that. We need to have a cancer treatment center. Very recently, we were told that we were listed among the hospitals to be given, ELINA accelerator, ELINAC and all that. I think I did reach out to His Excellency because it's not just the equipment itself. You need, a center, that can house this and all that. So that's a very major gap in the state, which I hope can be addressed because a lot of our people are dying from cancer, which could have been prevented. For me, I think I want to use this opportunity as let's have a car. It doesn't even matter, even if it's in the state government facility or here. The most important thing is that the people of Akwa Ibom State can access that for treatment.
Thank you so very much, Prof. And still talking, you made mention of insufficient funding. I don't know, have you been trying to explore alternative sources like maybe the foreign donors or those in the diaspora or whatever means?
Maybe it's a cultural thing. Why am I saying this? Because until recently, I was chairman of the Committee of Chief Medical Directors of Federal Tertiary Hospitals. That's across for the last 3 years until recently. And that meant that I had traveled extensively across the Federal Tertiary Hospitals, especially in the West and the North. What I see, you go and see an entire block built by an individual and donated. I've not seen that here in New York. I have, in all honesty, I have approached a lot of our major, stakeholders for assistance, and some of it has not been forthcoming. So it makes you look like a beggar.
That's true.
And again, a lot of the companies, one would have expected that this being an oil-producing area, that would have a lot of the oil companies assist us. I would want to say, let me thank the NLNG, Nigerian Liquefied Natural Gas.
Yes.
A couple of years ago, they helped us to renovate the accident emergency. As at the time we commissioned that was about 3 or 4 years ago. Yeah, that was about 3 years ago. Yeah, a little bit over 3 years ago. It was probably the best in the country. Of course, recently, because of overuse. That accident emergency is more than 100% occupied at any time. So continuous usage. A lot of the equipment have since become faulty and all that. So I want to thank them. Now, the very sad news, and I'm going to call them out, is that in 2017, a groundbreaking for a trauma center was done in this place, done by the then governor. It was to be built by Mobile Producing Nigeria. Up till now, the ground has not been broken. And I think that is very responsible for a corporate entity to come and do groundbreaking by a whole, bring a whole governor to do. It's not the governor's fault, it's that fault of the company.
Yeah.
So that was, groundbreaking was done. And up till now, the ground has not been broken. So when you look at some of these things, you begin to wonder, really. So I think maybe it's a cultural thing, because in Lagos, in UCH, all this other Western, you see a lot of projects, companies.
Yeah.
Yes. Here, there's no support. So that's a tragedy.
It's a serious challenge there. And now let's look at the Japa syndrome.
Okay.
A lot of health professionals are leaving this country, and I'm sure UUTH is also affected.
Yeah.
So how are you managing this?
Japa syndrome, I think it's a global thing. They are good, it's good and bad. Let's start with the good. The good is that when people leave, some of them eventually come back, but they have gone to experience the best practices. Did you hear me? Some of them come back, because we've seen some come back, especially those who went to Saudi Arabia, took leave of absence.
Okay.
The ones that go to Saudi Arabia and the Gulf states come back because it's a tenure, the contract. So they come back, and for many of them, they've gone to see and observe some of the best practices. So they come back and help to impact that back. And then number two, it also, on the good side, could we have really absorbed all our health workers? Where are the jobs? So again, it helps to take, provide jobs and livelihood for people. But the reverse side is that, yes, especially among the nurses, too many of them have left. Too many. And the ones that go to Canada, the UK and the US don't tend to come back, especially Canada. and the UK. They don't